Dear ladies and gentlemen, dear colleagues, you are welcome to the third edition of the EUROSON POCUS School, and it's a real pleasure to be together with you on this great conference. I have some words to starting this conference, and let's see who are the European Ultrasound Working Group in the ambulatory healthcare in the family physicians. And the evolution of the point of care ultrasonography in the last decades has grown exponentially, and multiple European societies have adopted, given the recommendation for the uses of the point of care ultrasonography application in the daily clinical ultrasound examination in various medical specialty, including in family medicine. And you can see this evolution starting in the last decades in 2011, and we have a lot of recommendation in these times, and the European Ultrasound Working Group have the same evolution. We starting 10 years ago, and how did this idea come to practice the point of care ultrasonography in family medicine in ambulatory healthcare in daily practice? And in 2011, I read an article in the New England of Medical Journal, and they appear a lot of point of care application, but in different specialties, but wasn't the family medicine, wasn't pediatrician, and so on. And we want to build this point of care application curricula, and you can see this how you can create this point of care curricula. And you must have the application to be included. You must make the enhancing selection of the application through the medical doctors, and also you must make the methodology of training of each application. And we starting with this curricula, and in 2015 in Romania, we made the curricula for the family medicine of the point of care ultrasonography. And also we made an European survey to find what application was fit in our specialty. And you can see the importance of this topic was revealed by the publication in the Wonka World Book of Family Medicine in Ibero-American edition in 2016. And we have a chapter, the evidence of the point of care ultrasonography in family medicine. And also we use the artificial intelligence in our practice, and we built an intelligent algorithm software launched by us at Wonka Copenhagen conference in 2016. Also, we built an survey, an European survey, and which questions were sent in the European networks, EURACT, EGPRN, and Wonka Europe. And we have more than 450 responders to this European survey to find each application is for the family medicine. And you can see a lot of application. We try to implement the point of care ultrasonography or focus or rapid cardiac assessment, and we make a questionnaire, and our responders have majority vote to the rapid cardiac assessment and to evaluation of the left ventricular size and function. You can see also the similarity between the anatomical image and the ultrasonographic image in these images. Also, we try to find what application it's from the vascular diseases, and the majority vote the deep thrombosis diagnosis of popliteal and femoral vein. And also, as you know, we had the pandemic, the COVID-19 pandemic, and we are also in the pandemic. And we try to find some application for thoracic pathology to use this in the daily practice, and especially in the remote zones. Because in the remote zones, you don't have the radiology as a family physician or as an ambulatory healthcare specialist. And you can find this application we try to implement in Romania to our family physician and also to ambulatory healthcare specialist. And we use it all these views or these scans, and we try to promote because it's very easy. If you can see in the normal lung, you have these A lines, and in the partially aerate and in congestion of the lungs, you have these B lines, and it's very easy to find in the ultrasound image. As you can see, this image, you have the E lines and you have the pleural lines, and also in the second image, you can observe these B lines, and you have the lung congestion in your patient. And also you can find the presence of the pleuresis, and you have a lot of signs, and you can use this in daily practice. And also we try to implement some application of point of care in the pediatrics, point of care, and also a lot of application in the abdominal, in the pelvic ultrasonography. Also, as an organization, an European organization, we try to make a lot of workshops in all the Europe. And also we participate with these workshops in the EUROSON Poznan conference, and in 2018 with our colleagues, Mateusz Koziak and Dana Stoyan, Professor Dana Stoyan. And also we have a real success there. And also we try to implement this kind of workshops of point of care in to the Europa conference in Israel in 2018 with our Professor Shlomo Winker. And there we had 4 workshops for the family physician and also for other specialties. And also we try to implement the workshops in the Krakow, in the Wonka Krakow, and also the first edition of the Point of Care Ultrasonography in 2019 with Professor Adrian Săftoiu as a EFSUMB president in that time in 2019. And also this was kind remembers about the work, EFSUMB endorsed course in the workshops in Vienna in 2019 with the great presenters as Dr. Ilse Hellemann from Austria, and also with our colleagues from Romania. And also in Bratislava we have a lot of workshops, and we try to make and to implement the European projects in different countries. And this was the first our project, the cross-border project in 2019. It was a project of 2 billion euro between Romania and Serbia, and we have more than 30 investigators, more than 20,000 patient questionnaires, and more than 6,400 patients examined to ultrasounds. And the VIENNA has launched some clinical studies, and you can see some studies of the focus in family medicine, or the rapid assessment of the focal lesion in parenchymal organs, or the ThyroScreen project. And also we try to launch some educational project of PoC-US application for the family physician, and our project has entitled Family Son Project. And we continue with to launch some projects in our daily work. And this was the second edition of the EUROSON POCUS School Vienna last year, and was the first conference who was organized in real with physical presence in last year. And we have a great successful. And also we participate to the EFSUMB conference in Timișoara, and we had was the chairman in the section of the family physician, and also we tried to implement some POCUS application for the students in this congress. And also we have published several books and atlases of clinical ultrasonography, and this year and last year. And finally, you can observe here a nice image, and something is not very well fit in this image. You can specify me what is not normal in this image? Someone of you, please try. It's a boy. Okay, thank you. You are very well, and you have a good eye for the examiner in the ultrasonography, because there was a boy. This is a market in the Jerusalem, and in the old Jerusalem market, and this was the conference in Jerusalem in Israel, and also this was the conference in Vienna, the POCUS in Vienna, and this was the conference and our workshops in Serbian. And finally, we must also mention the independently of the continent, the country, the religion, the family doctors want to learn POCUS. And ladies and gentlemen, we are welcome, and we declare open this conference. Thank you. We invite
So good morning, everybody. It's a great pleasure to me to be here today for the second time. I've been here last year. I can see some figures in the audience that I already recognize. And many thanks to Mihai for the organization of this very, very important meeting and the vision for the concept of point of care ultrasound in family medicine. So my name is Professor Winker. I'm the president of Wonka Europe, and I'm also the chief medical officer of one of the healthcare organizations in Israel, Leumit Health Services. Do we have anyone from Israel in the audience? No. So I know, but anyway, this is one of the healthcare organizations in Israel, and it is important to note here because I'm pushing point of care ultrasound in my organization for many years without a big success, mainly because of the costs. But now I'm happy to tell you that at least in Israel, point of care ultrasound will become mandatory from the next year in the training program of each of our trainees from now on. So the healthcare organizations will be forced, they didn't volunteer, but now they will be forced to buy the equipment and to make training for the teachers for the future. So it is very important. I'm also the Vice Dean for Community Affairs at Tel Aviv University, and I can tell you also that in our university, Point of Care Ultrasound is part of medical studies for a couple of years. So I will start with a few words about WONCA, the World Organization of Family Doctors. And as you see, the acronym doesn't fit exactly to the words of family doctors. So it is something historical, and the acronym is World Organization of National Colleges, Academies, and Academic Associations of General Practitioners and Family Physicians. A very long name that practically no one uses. Actually, we are the World Organization of Family Doctors. Our mission is to improve the quality of life of people, to foster and maintain high standards of care in general practice and family medicine, to promote personal and comprehensive and continuing care for the individual in the context of family and the community, to encourage and support the development of academic organizations of general practice and family physicians all around Europe. We have 47 member countries, more than 120,000 family doctors in our associations, and we used to have 12 networks, and from this year we have another 2 special interest groups, so altogether 14 networks and special interest groups. This is our new executive board that have been partly replaced in a few months ago in London. You can see me in the middle, and standing aside me is Professor Thomas Frez from Germany, who is the president-elect. And you may recognize others in our executive board. Our goals as WONCA is to achieve universal coverage through family medicine in all of Europe, to advocate integrated care to be implemented horizontally in primary care and vertically between levels of healthcare, to support the development of undergraduate curriculum with focus on family medicine, and of course the specialty training in family medicine in all Europe, which surprisingly is not nowadays mandatory in all Europe, and strengthen the research base of general practice family medicine. Pay attention, this is also very important for point of care ultrasound in family medicine, and the need for research, to strengthen the safety and quality in our work, and of course to attract new and future general practitioners and family physicians. What is new since our last meeting in Vienna just a year ago? I ended my lecture last year saying PoC-US represents the family medicine of the future. This year I will try to share with you the progress that was made since then. So just a reminder, this is from the American Academy of Family Physicians, and this is studies that were done about point of care ultrasound in primary care. And as you see, we are checking the lung, the heart, aorta, abdomen, obstetrics and gynecology, musculoskeletal, and many, many other areas. But in general, from this slide, you can see that point of care ultrasound is something that takes time, and also this is a summary of the research done, and you see that there is not enough evidence-based medicine evidence. So what can we see in the bedside in primary care with the use of point of care ultrasound? We can search for abdominal aortic aneurysms. We can have, and we will see later on during this day and tomorrow about evaluation of left ventricular systolic function. It is very important and relevant while looking for abscess and foreign bodies. Musculoskeletal ultrasound is very, very important in primary care. And also for procedures, and we'll see about how to place needles exactly in the place that we want them to be. Of course, abdominal ultrasound, about pulmonary congestion, renal, about hydronephrosis. I can tell you that a few days ago, I got a reply. I'm not doing point of care ultrasound routine in my clinic. So I got an answer of a patient that have UP junction stenosis with a very dull parenchyma of his kidney, and he is a patient with severe diabetes, and for many years I thought that his renal dysfunction is related to this diabetes, and I went through his medical file and I found that 2 years ago his both kidneys were normal by ultrasound. So I presume the deterioration of his renal function for the last 2 years is related to diabetes and also to this anatomical problem, which is quite a pity because it is a reversible problem, and we could avoid his renal deterioration. So if I would have, and of course I cannot send him to do such an ultrasound every couple of months, but if it would be a bedside ultrasound, I think that the prognosis was much better. So I will start my review from medical schools, and as you can see, this is a study from the United States. All my citations will be from 2022, just to say what is new in the field since our last presentation. So what we can see is that in the United States, most of the medical schools already now, those that answers this survey, are using point of care ultrasound, but as you can see, there are some obstacles or barriers. One is a lack of trained faculty. Again, this is a problem. We have to teach our trainees together with ourselves, and also not enough time for the current curricula, and lack of equipment. And as you can see, a point of care ultrasound is emerged during all the medical school. In the United States, it's only 4 years, so this is the reason why you can see only 4 years, and also around all the preclinical and clinical studies. So you see that there is a need of point of care ultrasound around the curriculum in the medical school. But if you will see what is taught in medical school, you can find that it is only partially relevant to primary care. So the new residents, our new residents, will have the basis, will have the knowledge how to use the technology, but still we will have to train them in what is relevant to family medicine. What about residency program? Well, I didn't find a lot of new literature in the area, so I find only one study from Zambia, which is low middle income country, but again, they found their clinical ultrasound very, very relevant for the daily care, and they say that in 2/3 of the times, the point of care ultrasound changed the management of the case that was studied. But again, as you can see, what is relevant to low middle income countries is less relevant for more developed countries in Europe. And here again, you can see that in this study, in many cases, the point of care ultrasound was used to determine a diagnosis or to rule out an alternative diagnosis. So when we are introducing a new technology, and the vast majority of our family doctors around Europe are not using point of care ultrasound, they didn't learn to use it during their training program or in medical school. So then continuous medical education is also very, very important. So this is a study. It is from, as far as I remember, it's from Sweden, and it is nice to see how family doctors are learning this new competence. So it was a study that was dealt with interviews of general practitioners, and they found that those family doctors were self-educated. They got the basic point of care ultrasound competencies by training sessions at hospital departments, or they took courses, but they expanded the skills through additional courses, continuous self-study practices on patients often while consulting internet sources, textbooks, and colleagues. And this is how they summarize the way, the trajectory of a family doctor that is starting to use point of care ultrasound according to this Dreyfus and Dreyfus model. So we started with medical school, went to the training program, to the continuous medical education, and what about the effectivity of point of care ultrasound in primary care? So I found several studies about this topic. Here is the list of them, and I will go through each one of them quite shortly. So the first study is a systematic review about ultrasound on clinical outcomes. Again, low resource settings. The reason that studies are done in low resource settings because the alternative to send the patient to the ultrasound is very difficult and very challenging. So this is the reason why studies are done there. And no study proved that there is an outcome of reduced mortality, which is quite clear. From the beginning, I'm not sure why to do a study like this in primary care, because most of our activities have not any immediate impact of mortality. I think that we should study more to be focused on how the clinical and evaluation process is going, about the process, about changing differential diagnosis, about the length of time from when the patient first appears in our clinic and when we are reaching a final diagnosis and definite treatment. And I'm sure that we should not focus at all about mortality. And as you can see, that point of care ultrasound changes between 15 to 52% the management and the diagnosis of the patients. So they summarize that PoC-US is a valuable intervention to consider in resource-limited settings, and I would say also in other settings, with the potential to change diagnosis and patient management, which this is the important thing that research should be focused in the future. Another study was about the perspective of general practitioners. This study came from Denmark. Denmark is a country which introduced point of care ultrasound for primary care for many years ago. And so they can now see what is the outcome of this training of point of care ultrasound. And I will jump directly to their conclusion. In this cohort study, general practitioners performed ultrasound examinations of anatomic areas with or without a defined clinical suspicion, which means if you are doing an ultrasound where there is no suspicion, the chance, and we will see it later on during this day and tomorrow, to find incidental insignificant findings is high, so you have to be careful. And another thing that they found is that some performed ultrasound examinations for which they had no previous training or skills. Again, we know that this examination is very highly dependent on the examiner. So to do tests, to do point of care ultrasound examinations that you are not qualified and you have no training, again, may make more damage than advantage. And this last study that I want to present to you is that, again, this is a practical use of point of care ultrasound in primary care. And again, you can go back to the article and to read all it in details. In this article, there are also some nice photos of these procedures. But the most important thing to do is to deal with the policy, which I mean, we can start everyone can go back home and to say, okay, point of care ultrasound is important and I will try to progress it in my institution, in my healthcare organization, etc. And as I show you, I'm a great believer of point of care ultrasound, but without outside enforcement, by changing the policy in our medical association that forced trainees in family medicine to practice point of care ultrasound, I was not able to change the opinion of my managers to introduce this technology. So one important step that we did in policy is that in our London conference, we started to write a policy statement about a point of care ultrasound. As you can see here, the name of Mihai also, you can see it. So we are pushing this statement, which is very important to Europe. We had some comments in the council meeting, in the last council meeting, and now we wrote it again, I think in a much better format. So the statement, as you see here, that was introduced to our council a few months ago will be changed, but I think that or during this year or uh, last chance is the next council meeting, which will be in Brussels next summer. We will have a policy statement from Wonka Europe, the Association of Family Doctors in Europe, that time come to adopt point of care ultrasound in primary care. I think again, it's a paper, but it is a very important paper for each of our member organizations when they are coming back to their country, to their stakeholders, and to show them, okay, uh, now this is, let's say, the standard, the evolving standard in Europe, and we all should adopt it. So in summary, point of care ultrasound implementation in primary care and family medicine is progressing. The plan should be multidimensional, as I showed you. It should focus on training in all levels and also influencing policy makers and stakeholders. So I'm sure that next year when we will meet here all together, we will have other good news about the implementation of point of care ultrasound around Europe. Thank you.
Introduction to the general ultrasonography based on the section and standardized plans for the daily practice of clinical ultrasound in ambulatory healthcare. The point of care application and the examination techniques and sonoanatomy. This is the very important things to have a standardized guidelines, to have a standardized examination of the point of care in all the ambulatory healthcare. As you know, the point of care ultrasonography represents the ultrasound investigation done by the clinician at the patient's home or in the family doctor's office or in ambulatory healthcare office with the purpose to find an existing lesions early in their primary stadium, as I said, to guide and lead the treatment's management. The miniaturization and the price reduction of the medical ultrasound devices represent a big advantage for all of us as a physician. The point of care represents practically an extension of the clinical examination in the family doctor's practice, and we said the clinical ultrasound examination is an upgrade of the classical clinical examination. It is the right hand of the medical specialty who are playing a main role in the acute pathology and also in the emergency, especially in the family physician, as I said, and represent, and we could say, the ultrasound could be the third eye of a physician. You can see in your patient. And with the help of the point of care ultrasonography, you can obtain both the confirmation of a clinical diagnosis presumed as a positive diagnosis, and also you can make an exclusion of a particular pathology, and we can do the differential diagnosis. We have some positive aspects, as in most cases it completes in a primary clinical investigation with valuable information. It is quick, it's real time, repeatable, and also is non-invasive and is very cheap now. And we have also some negative aspects. It is an operator-dependent method and depends on the expertise of examiner. We have, as I want to say, this is very important. We have three determining factors of a correct ultrasound examination. The first factor is the examiner's expertise. You must have some expertise to put a real diagnosis. A second is the ultrasound machine, the quality of the ultrasound machine. And the third, and not the last, it is the patient preparation. Patient must be in the fasting mode or so on to have a good image, to not have the artifacts in your image and to put the wrong diagnosis. As the ultrasound as a technical principle, you know, but I want to remember you, the piezoelectric quartz crystals send ultrasounds that travels through the tissue until they meet a high density object, and then sends the ultrasounds reflected from the interface back to the transducer. The ultrasound is received by the crystals, then turn them into electrical charge and transforming in an image with the modulation of the ultrasound machine. We have some different biomaterials as air, as water, blood, fat, muscles, and the ultrasound speed are different between these, and this makes the differentiation and the interface between the tissues. When you choose a probe, you must have in your mind the deep and the resolution versus. And you must know in the first, if you want to see in the abdominal ultrasonography or the pelvic ultrasonography, you must have the convex probe with the low frequency, with the high depth penetration, but with the low resolution. If you want to see in the bowels, in the breast, in the thyroid, you must have the linear probe with the high frequency between 7.5 and 15, let's see, and you must have the high resolution with the short depth penetration. you must choose the probe depends on the topographical examination. And also, you must know the probe have an indicator, and the indicator of the probe to be standardized must be to the right of the patient in the abdominal examination, but is some difference in the cardiac examination when the indicator must be to the left of the patient. And I want to highlight this from the start. And you must know in every moment where you are with your hand and your probe in the patient, and what is the section of the image of you use in this examination. And also you must know you have some planes, is the sagittal planes, is the transversal planes, and the coronal planes, and you can use all these planes to make a views in your patient. And also we use the topographical location, the hypochondriac, the epigastric region in the upper abdominal, the lumbar, the umbilical, and the right and left lumbar topographical, and also the hypogastric and the iliac zones and regions. And also you can use in all these regions some kind of section, the longitudinal, the transversal, and also the coronal section or frontal section, as you can see. It's very important to know that your ultrasound probe is like you can make it's like a knife. You can make the section in your patient, but you must know if you make the longitudinal section on the monitor, when you look to the monitor, to the left of the monitor, you have the head toward the head of the patient, and in the right of the monitor, you have the feet of the patient, and upper you have anterior part of the patient, and back behind you have the posterior part of the patient. This is the orientation of the patient on your monitor when you put the probe to the patient. And you make the transversal plane, you must know you have the right of the patient, the left of the patient, and also the anterior and the posterior of the patient. You must know in every moment where you are with your probe and how is your orientated patients on the monitor on the desktop. And to the clinical ultrasound examination, allows you to obtain the following responses. It's a fast orientation to the type of the suffering of the patient, acute, chronic, and complicated, organic or functional of the patient. The localization, the clinical topography, the organ pathology, you can have the answers, the presence of diffuse or the focal pathological lesions, and also you have response about the vasculature and of the stiffness with the Doppler triplex ultrasonography, and also with the elastography, the strain elastography, and also with the shear wave elastography. You can confirm the presence of aeroenteria, the pneumoperitoneum, and the presence of the abdominal fluids like localization, cloisonation, and nature, the serous and purulent hemorrhagic collection. And also to the digestive tract, you can have the answers about the distensis, the stenosis, the wall change, and altered peristaltis. And also to have the complicated vascular aneurysm and so on. And when you have a patient and coming to your ambulatory healthcare, the patient comes with a problem, with a symptom. In this case, the patient comes in our praxis with the pain in the right hypochondrium. And you can see and you can think about your patient. He can have biliary colic and so on. But in these times of the COVID-19, you have many cases with the pleuresis. And this was a patient who comes just with the pain in the right hypochondrium, and he has a pleuresis and has COVID-19. This is the reason we advise you to use the ultrasonography, the point of care ultrasonography, to put the probe to the patient who comes with the symptoms to you, and to put the probe on this topographical region and near this region to see if it's not some other problems, like in this image. And you can see the presence of pleuresis here, and this is the diaphragm, and here is the liver, and patient had pleuresis. And the main problems with the patient comes to the family physician and the ambulatory health care, I tried to make a study, and we obtained some such results as the pain was the most important sign with the patient comes to us. The visceromegaly was the second. The tumor masses was the third, is as incidentaloma. The jaundice, the neoplastic syndrome, the fever, the hepatic, biliary, and pancreatic pathology, and also the retroperitoneal pathology, the hemorrhage, the thrombosis, and also, as I said, the incidentaloma. It is very important because the patient come in your praxis with the symptom, and then you must make the history of the patient, the anamnesis, and you must make the clinical examination, the classical examination, and finally, you put the probe. If you have devices in your pocket, you can put the probe on the patient and see in your patient what it could have this patient in your consultation. And it's very important because we find the anamnesis and the clinical, just with the anamnesis and the clinical examination, allowed us to put a correct diagnosis in the 49% of the cases. If you use the anamnesis, the clinical examination, and laboratory examination, allowed us a correct diagnosis in 59% of the cases. And if you join the ultrasound examination, the clinical examination increased the chance of the diagnosis in 86% in our study. Let's see, you can put in 90% of your cases the diagnosis with the help of the anamnesis, the history, the clinical examination, and ultrasound machines, and laboratory, of course. And you can solve a lot of cases in the primary healthcare or in ambulatory healthcare to not refer the patient to the hospital where increase the cost. This is some, when you have a patient with abdominal pelvic emergency pathology, you must have in your mind some pathological diagnosis. And you can see in the upper abdominal, in the right upper quarter, and then also in the left and the right and lower quarter. And you can have all this diagnosis in your mind. And if the patient comes to you, you can have a suspicion of this diagnosis, but with the help of your ultrasound machine, you can make the positive and also the differential diagnosis, like in these images, the nice images. When you have all this kind of pathology, depends of the topographical region of your patient. And in this way, we can increase the diagnosis accuracy, of course. Also, you must have an ultrasound protocol you use to not, if you want to make a general ultrasound, not in the point of care. If you want to make a general ultrasound, you must have an ultrasound protocol. And we design some such protocol. And we starting the clinical ultrasound examination of the right of hypochondrium and counterclockwise on standard section and planes in the fast mode for the patients. And also we create and design a point of care ultrasound protocol, electronic or protocol. And you put all the data here you can find. And you have a diagnosis algorithm in this ultrasound with the artificial intelligence also. Because we try to find some ratio between the organs, and you can, in the next few days, we try to explain you what ratio we find in our studies. In the sonoanatomy, the ultrasound examination of a parenchymal organ could specify the following: the organ shape, the contour, the position, the echogenicity, the echostructure, and also you must have in your image the landmarks to have a standardized image. And you have some landmarks like vessels, like xiphoid appendix, like pubic symphysium, like iliac crest and navel, the rib cage, axial spines, blood vessels, and so on. And also you can find some answers about the vasculature of the organs, the stiffness of the organs, and the presence of the diffuse and focal pathological lesion. You can find the diffuse lesion and you can refer the patient to the specialist. You can find the focal lesion, could be benign or could be malign. You refer the patient if you don't have the knowledge to solve this case. But it's very important to put the early diagnosis in the family physician and in ambulatory healthcare, of course. The good quality of the ultrasound image
displays a median value.